So I'm going to just go from the more clinical side of things now. So thanks, Mark. Yep. So could you change? Oh, right. Thanks very much. I mean, we've seen, I think Mark's very well established that scarring is a significant issue that we can change, but I just thought I'd like to show you some of the real scarrings that we see. We're not talking about always just cosmetic scarring. I often feel is more than skin deep, and it has a profound effect on people over their life, and as we've indicated, it's persistent, it turns over. That gives us an opportunity for improvement and treatment, but it also means that this person has to wear this for life. As you can see in this small child here with a burn injury on the chest and up into the neck, that child will never move normally again. So it has a profound effect on your total body function, as well as in certain circumstances. You can see on the other side, the clinical photograph there of a skull going beyond the zone of injury that's expanding. And with that expansion comes the itch, the pain, the other symptoms of this scarring that influences the capacity for persons to function and to sort of ignore them, if you like. So it's more than just what something looks like, it's what it feels like and how it affects the rest of your body. And so what we're trying to do is understand, how can we unscar the scar? How can we change that phenotype of the fibroblast back to a normal skin phenotype, or back in that direction? And we know, as Mark said, that there's an interplay between the cell and the matrix around it. So if we can change that matrix, we can change the cell functionality and change that scar quality and move back towards normal skin over time. Thank you. So when I treat a patient with skin loss, and I think I can talk about skin all day, I can talk about skin until it all turn to dust, because it does so many things. Certainly it gives us our waterproof layer, our barrier to infection, but it's also involved in our vitamin D, is involved in the bone and hemostasis, and linking that with the sunshine, and the immune system. Why do we blush? It's intimately involved with our nervous system. So there's all this functionality that, when it gets damaged, is impacted. And so how deep the burn or the injury is depends on how you treat. And so when we go all the way through the full thickness of the skin, we're having to try and work out, where can we borrow Peter to pay Paul? How can we harvest donor sites, remove that skin from a non-injured area and put it into the injured area? How can we facilitate the healing of a major wound, as you see, and this adult patient here with an 80% body surface area burn? Well, yes, we can survive such massive injuries, but it comes at a cost, and that cost is scarring. And it influences the functionality going forward with respect to this. As the scar develops, it sort of crowds out, if you like, or damages the capacity to develop sweat glands, hair follicles. So the other functionality of the skin, other than the wear and tear barrier and the waterproof barrier, they become compromised. It comes compromised in its immune response, etc. And we have to protect from sunshine. And so one of the commonest injuries we see here is a scald injury. With our cell-based therapies, 80% of our children with this particular injury have no visible scar, but we see changes underneath the surface. And we see those changes influencing systemically that individual. So we've got our standard of care, if you like, on how we can repair those wounds, but we have a real clarity of understanding of how that isn't delivering a regenerative pattern. It's not delivering normal skin. What we do is we have a scar repair, and that scar repair has a significant influence for life. Thank you. And one of the key things which I thought I'd put on the table, we can discuss as we go forwards this morning, is the time to healing. And I think this whole LOX inhibition pathway, like, we've got inflammation, we need inflammation to heal. But when inflammation becomes extreme, it drives that poor scar outcome. And that inflammation is perpetuated the longer the wound is open. So by modulating this and reducing the time to healing, we can reduce the scar. And that is one of the very few things that we absolutely categorically know in this space, is that if we can reduce the time to healing, we can reduce the scarring. Thank you, Mark. I'll come back to that later. So what is our current standard of care? And I'm sorry about this sort of like this busy kind of slide, but I wanted to go through this in a real depth, because what we have right now, as you've heard from Gary, actually is quite limited. The one thing I know is that if I get a wound healed within 10 days, then only a very small percentage of people will have a scar. If that wound isn't healed until 21 days, then 74% of people will have a scar. And that scar is for life. We may be able to modulate it, change it, but it's for life at this point in time. And the scar, as we've heard, goes from our immature, hypertrophic scars, which we can improve with our topical therapies potentially. We have to define the scar for our treatment. So we've got linear scars, surgical scars. In many people, they may fade to a reasonable level, but there are hundreds of millions of people with surgical scars that haven't improved to a reasonable level. And we've got then the keloid scars, the scars that then go beyond the zone of that injury. And that could be a minor, it could be a major situation. And then the burn scars. And the burn scars have a very characteristic hypertrophic response that is associated with the itch and the pain, etc. So what is it that we do about it? Number one is we try and heal as quickly as we can. Number two, then we need to look at the surface of the scar and see what we can do. And so basically what we have in our toolbox at this point is silicone sheeting. A small molecular weight silicone topically has an impact on some scars some of the time. It's a trial and error. We put it on sometimes under pressure garments, and I'll come back to that, or sometimes just in a topical cream. It will have an influence, as I say, in some people some of the time. It will hasten the maturity, but it does not eradicate the scar. And it only does that in certain individuals, and in other individuals, a small percentage, probably coming up to 8 to 10%, it causes a reaction and we have to stop it. In some instances, when this scar gets out of control, historically, steroid was the only thing that we could use. And so we would use that steroid, but now we have laser therapy. And so we have a capacity to fractional laser to alter the scar by using the laser, which initiates microthermal zones. And sort of, it's a bit like in my headspace, it's a bit like in those older ones amongst us, banging the thump in the top of the television to get the very horizontal hold going. It's a bit of a sledgehammer to crack a nut. But we're learning all the time on how we can control those microthermal zones to get the right kind of balance so we can remodel the scar. Pressure garments is another thing we use very widely, but does pressure in itself influence the scar? And this is something that in my field is debated long and hard. Pressure garments facilitate edema control. By controlling edema, you control inflammation, and you can have a positive effect. But that's in the short term. In the long term, do pressure garments influence the oxygen transfer across the surface and at the cellular level? Does it change the mechanobiology? Is it a combination of these things? And again, it's not something that is foolproof and works at everybody all the time. And so we play it by ear. We tend to use pressure garments when the scar has a vascular response, when the scar is red, and then we push that pressure until the redness starts to dissipate, and then we pull back on the pressure. I think it's interesting that We measure our scars in terms of what they look like. Are they red or purple or angry, sort of vascular, the vascular response, how florid is that? What the pigment load is like. Are they pale? Are they dark? What does it feel like? Is it lumpy? And is it pliable? And so all these things, these subjective things, come together to give our scar management, our scar assessment. And we're trying very hard to look at assessments of scarring that we can use to become more objective rather than subjective about this, because that's one of the things that is a bit of a problem. And certainly there's all sorts of things that people do. Cryotherapy is occasionally, again, in certain circumstances, used in keloid scarring, can change the healing pattern, but not widely used. Things like introducing bleomycin and other oncology drugs into keloid scars, not widely used. Interferon, again, it's because we haven't got something that is reliable. We've done research looking at steroids in keloid scars versus calcium channel blockers, and we find that 50% of the scars will return within a year, even with steroid, which is considered the state-of-the-art treatment. And so I'm just going through what we have straight away, trying to heal quickly, uses topical silicone, pressure if you need it, and escape of control, injection with steroid and laser. And that's the sort of standard of practice. And then you start to get the more complex things with scars that are out of control. Thank you, Mark. This is just to show you that we can change things, and we try and monitor our changes in our, and we've got a suite of tools that we look at scanning the surface, and this is using OCT, optical coherence tomography, to look at just under the surface without taking histology and comparing the impact of our laser on a hypertrophic scar. Here you see on the shoulder, on the upper arm, and we're trying to understand how we can change that scar. And this shows the vascular pattern, the pattern of the blood supply within the scar, trying to drive it to a normal pattern as compared to the normal skin. And so these are some of the research, one of the research tools that we use, as I say, trying to get some objectivity around this whole space. Thank you, Mark. So we have an unmet need. We've got an unmet need in time to, one, prevent the scar, two, control the scar. And the holy grail is, can we unscar the scar? Can we change that scar phenotype back to a regenerative phenotype? And this matters because these scars are symptomatic: pain, itch, movement. The skin no longer flows over the underlying tissue structures. You may not be able to move your hand or your elbow or whatever normally. So you have that functional impact as well. So we really want to understand how we can control that extracellular matrix to drive a regenerative phenotype, not just in the acute phase, but way down the track as well. And then the other thing is, how can we integrate? If we repair a flap, take out a skin cancer, we bring a flap tissue in there, how can we integrate that so that we don't have a scar around the edge and underneath? So that integration of new tissue constructs. Thank you. So that brings us to the trial. We've done the first in human, and that's on our normal skin, and we've moved and got forward from that. And now we're using the topical cream in scars that are established scars greater than 1 year previously from injury, 10 square centimeters. And with our first cohort, we've recruited our first 8 patients, and we're taking serial pharmacokinetic bloods and biopsies, or punch biopsies of the skin before and during this whole procedure out to 2 months. We have our first patients just arriving at their 2-month mark, and we've been tracking these first 8 patients very carefully, as you can see here, with the checks, with the biopsies, with the bloods over time. Our next cohort, which we've just put out a Facebook expression of interest, so we're starting to get our patients coming forwards for us to survey, to make sure that they are suitable to include in the trial. And this 42 patient cohort that we will commence in April are randomized. Our first 8 all have the drug. Our next 42 patients will be randomized into drug versus placebo. They're less intensely followed, as you can see here, in terms of our bloods and biopsies, but we will be driving this out again to 3 months. And so our recruitment path will be April, May, June. So we will be finishing the trial by these established old scars in the sort of July, August, September. And then we will be moving into our acute work as well. So the part 2 with our acute work is looking at our burn injury patients. Can we stop it happening in the first place? So we'll be looking at 2 to 3 weeks. The epithelialization has been achieved, their wounds are healed, but then there's that sort of the maturation and the remodeling starting. So this will again also be a randomized controlled trial with a 3-month follow-up. Clinically, we can assess at 6 weeks, and we know whether that person is going to develop a scar or not, or become they'll all develop a scar, a troublesome scar. So we will be in a position with our 3 months follow-up to know that 3 months is when our scars are at their worst, and then they tend to mature after that. So in this situation, we'll be bringing in scar scanning, a 3-dimensional scar scanning technology, ultrasound, histology. POSAS is patient and observer scar assessments. And so that looks at both the symptoms and the appearance of the scar from the patient perspective and from the observer, such as myself. And so the other thing is how many of these patients will then go on to require secondary interventions such as steroid and lasers. Laser is our first-line therapy these days. And so that's is the next trial that will sort of roll on, flowing on from our chronic established scar work. Thank you. And I think that's where we can answer all the difficult questions you have for us.
Thank you very much, Professor Wood and Dr. Fiat.